I've been asked to talk today about meniscal repair using the newest fixators, and I want to thank you for your excellent talk. You covered a good deal of what I was going to say, but we all know that the meniscus is real important, and it does a lot of things. Load transmission, shock absorption, lubrication, stabilization, and helps with proprioception. And a meniscectomy, even a small meniscectomy of 30% of the meniscus can lead to changes in load bearing and lead to late degenerative changes in the joint. ACL reconstruction follow-up 10 years later with a normal meniscus and cartilage had almost 90% normal x-rays, but without the meniscus that incidence is not nearly as great. Meniscectomy shortens professional football careers. 81 athletes, 9 years post-meniscus repair. Degenerative joint disease was present in 60% of the patients who had the meniscectomy, but only 20% who had repair. And the pre-injury level was achieved in 96% who had the repair, but only 50% who had no repair. So the meniscectomy is not a benign condition. In a multi-center cohort series looking at the incidence of ACL surgery with associated meniscus repair, the MOON study group reported in 2009 the incidence of medial meniscus repair with ACLs was around 11%, and the incidence of lateral meniscus repairs was around 5%. I looked at my own group and I found that my repair rate of all meniscuses, all comers, is around 6.5% of my meniscuses get repaired. And 70% of these repairs are with ACL tears. And the problem is with a meniscus that is suitable for repair, if you take that out, you're going almost all the way into the red zone near the synovial meniscal junction, and that's often equivalent to a near total meniscectomy. So the meniscus is important, and meniscectomy is not benign. And repairing it is the desired goal, and blood supply is essential for healing. So I don't recommend using a tourniquet. I don't use tourniquets on any of my knee surgeries, ACLs or meniscus repairs, because it helps you see the bleeding. And if you use hypotensive anesthesia in the knee like we do in the shoulder, you don't have the problem of obscuring your vision even during an ACL reconstruction. Can some of these tears be left alone? Yes. Don Shelbourne has talked about the posterior horn of the lateral meniscus, central to the popliteal hiatus. That's got a robust blood supply. Some of those tears you can leave alone, especially if they're only 1 centimeter in length. So short, stable tears, you can abrade them with a rasp. If you have a spinal needle or a trephine, you can do trephination to promote vascular access channels and help the healing. But you should repair an unstable tear. And what is an unstable tear? Well, it's one that displaces under the condyle when probing. That usually means that the length is greater than half of the meniscus. But you should not repair a degenerative tear. A degenerative tear will not heal. And how do you define that? That is one of those meniscuses that will roll as you pull it forward with a probe. You see delamination of the meniscal rim. You have multiple tear planes. It's not worth your while to repair that patient. So what are the indications? A vertical longitudinal tear in the vascular zone without degenerative changes that's got a good blood supply. I think that the odds are improved as you go more peripherally. Shorter tears do better than longer tears, and younger patients do better than older patients. And I generally cut off my repairs at around age 40. Maybe 42. I did a 42-year-old in conjunction with an ACL reconstruction last week. So the perimeniscal vascular plexus defines the difference between the red and the red-white zones. And I think it's perfectly acceptable to repair red and red-white, but if you get into the white zone, you're probably going to cause more trouble than it's worth. And the repair orientation should consider the collagen bundles. The collagen bundles of the meniscus are circumferential. That's what gives the hoop strength to your meniscus. So if you capture more of those collagen bundles with your repair, you're going to have a stronger repair. The classic repair, as you mentioned, is is the vertical inside-out 2-0 Merceline suture placed 5 millimeters apart with the zone-specific cannula system. And you get a good repair. You stabilize the joint, you eliminate the shear stress, you keep it coapted, that's fine. But we know some things about the meniscal repair data. Non-absorbable sutures are better. Making the stitches too central, it can cause buckling. If you have the stitches too close to the tear, it may cut out. And horizontal stitches do not capture the collagen and are weaker than vertical stitches. Well, is this still the gold standard? Ultra-high molecular weight polyethylene suture has revolutionized arthroscopic surgery, and I think that is the new standard. Your repairs should not use Merceline or Ethibond. They should use these ultra-high strength sutures. They are higher strength, they have less breakage, and they have many of them have equal handling properties. So what is the best repair technique? A suture repair has been shown to show superior biomechanical stability to device repair. Clinical success rates do not necessarily correlate with the strength of the repair, however, and the biologic factors may be the single greatest importance for healing. Picking the proper patient, picking the proper tear. There are anatomic considerations that you know about on the medial side and the lateral side. And one thing I wanted to emphasize is that Minus recently reported the aberrant popliteal artery is present posterior laterally in 2%. And what happens, this anterior tibial artery branches above the superior margin of the popliteus and is located just behind the capsule. So you have to be careful, recognize that in about 2% of the patients, there's going to be a big red surprise back behind the posterior lateral corner. The meniscal repair devices have evolved. You have first generation, which were the inside-out sutures. The second generation are all these tacks, staples, screws, and hooks. And the newest is the self-adjusting suture devices. Well, the second generation had all these different devices. They usually fail at less than 30 millimeters of 30 newtons of force compared to braided polyester, which is in the 70 to 80 newton range, although those may break during tying. They're easy to put in, they're quick, some of them are biodegradable, but the disadvantages is that they tend to break and they can cause articular cartilage erosions. And the number of implants are limited. You can't put 7 or 8 stitches to side by side with these implants. Sutures are not benign themselves, and this is an instance of one of my patients who I did a suture repair on, and there was a knot on the surface, and you can see what the suture did to the articular cartilage. So you want to make sure the knots are not on the surface. And that leads us to the newest generation, which are the self-adjusting suture devices. They maintain you should maintain the classic principles of repair, vertical orientation, not horizontal. The sutures contain ultra-high molecular weight polyethylene, and these super sutures are much stronger and they do a better job than just plain Merceline. There are improving insertion devices, and some of these have a biodegradable component. So we've done some biomechanical testing of these new devices. This is cyclic loading in a human meniscus. And we tested 2.0 Ethibond, which was a control against 2.0 orthocord, the FastFix 360, which is the latest version of the FastFix, the Marksman, CrossFix, OmniSpan, Cinch, and the Sequent meniscal stitcher. And I'll tell you a little bit about these. The FastFix 360 is just coming out in the United States. It has 2 peak anchors, number 0 ultra braid, a curved needle, a new insertion device which you see below, which is really has a good feel to it, and it has a self-locking sliding knot. The Marksman device, that is the machine, the gun that puts in the MaxFire repair stitch. That's made of max braid. It's got 2 5-millimeter polyester sleeves that go on top of the ultra braid. It has a curved needle with an insertion device, and it has a self-locking knot. The CrossFix is made by Cayenne, although Covidien is coming out with a very similar product. It has zero ultra-high molecular weight suture, an internal passing needle which moves it from one tube to the other. It creates a 3-millimeter horizontal stitch. It's very difficult to make this vertical. You can get it a little bit off, but it's such a big machine, it's such a big gun that inside the joint you're going to really scratch the articular cartilage if you try to make it vertical, and it just doesn't fit. So you basically get a horizontal stitch with a pre-tied Weston knot. OmniSpan, it's a DePuy-Mitech product. 2 peak anchors with 2 orthocord. Now orthocord has, in this instance, has 55% PDS and 45% ultra-high molecular weight polyethylene. Comes with curved needles, gun insertion, self-locking knot. And the knot, if you put the peripheral suture first, peripheral anchor first, and then the second one, that drives the knot to the top anchor and it buries it so it's out of the way. The sequent meniscal stitch is an all-inside continuous stitching device. It's made by ConMed Linvatec. It's unique. It has multiple peak implants, up to 7 of these. And it has the zero hi-fi suture, which is the ultra-high molecular weight stitch, and each implant locks independently. There is no suture on the surface. And what makes this so unique is that you put that device in the joint and you start stitching, and it's like a sewing machine. You put in your first stitch, then you rotate it to lock it, you tension the suture, you put in your second, your third anchor, and you just keep on going. And you can just go back and forth rather than putting in your device, then calling for the next device, and the scrub tech has to put that together, and then you go in again. So there are 6 different stitches that come with this device. There are many stitch combinations. You can make V's, W's, continuous. You can make X's. It can help you if you want to try radial repairs. There's a wide variety. And then there's the cinch. This has 2 peak anchors, 0 fiber wire. Now, fiber wire is different than all the others and different than OmniSpan. OmniSpan has the biodegradable suture. Fiber wire has a series of long little strings of ultra-high molecular weight polyethylene coated kind of like a climbing rope with the braided polyester coat. This has a dual needle insertion device and a self-locking knot. So we tested these devices, and we found after 200 cycles of load to failure, we found that they were essentially equivalent in strength, except for the Marksman, which was statistically lower in strength than the Ethibond. And in terms of the number of cycles completed, again, the Marksman was statistically less likely to work than the other devices. And you remember, the Marksman has basically a suture over a suture. It doesn't have a rigid fixator at the periphery. So when you pull on that suture, it's much more flexible, and it just didn't seem to hold in this particular testing environment. So the clinical observations I would make: first-generation devices do not repair the meniscus as well as sutures. Inflammatory reactions can occur with the biodegradable products, and these devices can migrate, and degradation of PLLA products takes years. We're talking 4 or 5 years to go away. The rehabilitation program may be different. We don't know, but it may need to be different than the classic polyester sutures, because you don't know how things are healing with the tacks and the screws, and no one has ever studied that. The newest high-strength self-adjusting devices may have yet different rehabilitation programs. So my rehabilitation program for these new devices are the ACL protocol takes priority. And that means full weight bearing, full range of motion, start with an autograft, start running in 6 to 8 weeks, pivoting sports at 12 weeks, full return to sports in 3 to 4 months with a brace. But if it's an isolated repair, in the first 2 months, immediate weight bearing, immediate range of motion, limit the flexion to 90 degrees, emphasize full extension. In the 3rd month, we start on strengthening and we work on getting more flexion, and by over 3 months, we start them going back to pivoting sports. The take-home message is the blood supply is important. The peripheral vascular plexus provides the healing. Emphasize that, improve that with rasping and trephination. Thank you very much.